Hello, everyone. Welcome to the next webinar in the series as delivered by the Safer Healthcare and Biosafety Network. Thank you all for giving up this time in your day to hear from our experts on the important issue of safety around handling hazardous medicinal products. The SHBN launched this campaign which is called Safer Handling of HMPs, at the beginning of this year, following a parliamentary reception last year on the issue. The campaign exists to try to bring education and awareness to healthcare workers across the UK of the impacts of occupational exposure to HMPs. Please do check out our campaign website, which I'll put a link to in the chat. And I'm delighted today to be joined by two experts around occupational exposure to HMPs who are going to deliver their presentations. So I'd like to introduce Sam Toland, who is a nurse consultant in cancer care and lead SACT nurse at Worcestershire Acute Hospitals Trust, and Alison Simons, who is a senior lecturer in nursing and midwifery at Birmingham City University. Sam is presenting first, and if you have any questions for Sam, please put them in the chat and we'll ask them after the presentation, and then Alison, and then we should also have some time for questions at the end and finish just before or on 1 o'clock. Thank you again for being here, and I'll hand it over to Sam.
Thank you very much, and thanks very much for the opportunity today. It's most welcome. Oh, no, stop sharing that one, sorry. It's a pleasure to be here. Alison and myself have done quite a lot of work on this in the past, and we have looked in a lot of detail, particularly from the nursing elements of handling hazardous medicinal products, and particularly in association with cytotoxics, because both Alison and I are cancer nurses, and so we've had direct experience of that. I am still working within that area and currently run a service in SACT. So this is something that at the moment is extremely close to my heart in terms of trying to protect all of the nursing staff that I lead in our trust certainly from a chemotherapy point of view. So yes, I'm Sam. I've been working in this area for around 26 years. So I've handled a lot of hazardous medicinal products myself, and have given a lot of chemotherapy as well over that time. And I quite like this picture at the front here because it's showing people running away. And I think that's what has happened certainly over the last few years, is people sort of running away from this issue a little bit, because it is a massive issue. But I do think it is something that we need to start thinking about a lot more and protecting our healthcare workers a lot more. So my slant for today is really looking at from a very much from a practical point of view and a sort of on the ground view of what's going on in our SACT services at the moment in particular. And I just wanted to mention how we've got to the point that we've got to, and how that's happened. And there's many reasons as to why we've kind of come up to this massive capacity issue that we have within SACT services. First of all, we've got more cancer diagnoses, so we know that more patients are diagnosed with cancer, but we've also got increased survival, and that is really down to the fact that we have much better therapies these days that we give to patients. So patients are living for much longer. So not only have we got more patients with cancer, we've got patients living for longer. We've got more lines of therapy, many more lines of treatment, and we've got much more complex therapies as well. So patients now will have lots of additional treatments. So it's not just a case of a patient will come in and have one drug. Very often they're having 2 or 3 or 4 or 5 drugs in any one sitting. So they've become much more complex. We've had additional indications for these drugs as well. So a lot of the newer therapies, particularly the immunotherapies, we give in different settings. So we give a lot more neoadjuvant, so that's before surgery or before another treatment. And we also give quite a lot of adjuvant, so that's after surgery as well. So as well as having more cancer, more survival, better survival, we're just giving more treatments in those different types of ways as well. We've also got a load of new therapies, and I've got to say I went to a conference last week, and it's phenomenal that there are constantly new drugs coming out. We get a new NICE approval roughly weekly, so that's around 50 odd a year of newly approved drugs within SACT. And a lot of these newer therapies, things like immunotherapies, are drugs that we haven't really had in our armoury for all that long. So we're talking sort of between 10 to 15 years maximum. And some of the very new therapies, things around things like bispecific antibodies, BITES, which is a bispecific antibody that targets the tumour cells and the T cells, the immune cells as well. And we also have ADCs, that's antibody drug conjugates. So that's antibodies that have a cytotoxic element attached to them. So we have many, many newer types of therapies. And as I say, some of these haven't been around really for all that long, maybe sort of 5, 10 years. And all of these all together really make the perfect storm for a SACT unit, because obviously we've got more patients coming through than we've ever had. Those patients are having more treatments, they're having more complex treatments, and they're having a number of different treatments at the same time. So we are just seeing this massive, massive mushrooming effect. Alison will like the fact I've said that. Mushrooming effect of treatments, because, you know, we've just got this huge amount now that's going on our SACT units every day. And it's getting more and more difficult to manage in every way. What we know is that we get year-on-year increases. So in our SACT units, we get around 8 to 10% increase year on year. As I said, we're administering a bigger range of drugs than we ever have done before. So that's inclusive of all of those treatments. Even though we've got these newer therapies, it doesn't mean we're not giving the traditional treatments as well. So we are still giving cytotoxics, and we're still giving a lot of cytotoxics. It's just that what we're doing is we're adding on these other newer therapies as we go along. And most patients know when they are in the unit, they will have more than one type of SACT at any one time. So the majority of patients will have a cytotoxic regime plus an immunotherapy or some form of monoclonal antibody or an antibody drug conjugate at the same time. So actually the length of time patients are sitting in the chairs is probably longer, because we're making those treatments much more complex. And when I say things have increased, as I say, I've been in this for around 26 years, and I can remember probably 20 years ago, we might see about 4 to 5 patients per shift on a SACT unit. Well, that's turned into at least 10 to 15 now. So you have to think about those numbers of patients that are coming through, and any single nurse on a shift may potentially treat 10 plus patients on that shift. We also do longer days. So for us in my service, we do 12-hour shifts. So again, that means we're extending the day, we're extending the number of treatments that come through, we're extending the amount of time that the patients are in the chairs for. So nurses who are now administering SACT are actually just being exposed to far, far more than they ever have been before. Not only that, a lot of spaces are an issue, and I know certainly in my trust we struggle to find any space for anything. A lot of the SACT units that I know of, particularly in my region, are not fit for purpose anymore. They're not big enough to accommodate the numbers of patients coming through. And not only that, because we're having to squeeze more patients in and more chairs in, often those spaces become much more enclosed. There's very little in the way of ventilation often. And obviously there's the increased risks of contamination, because the closer everything is, then obviously that's an issue in itself, because you're more likely to contaminate things that are directly around you whilst you're administering those medications. So all in all, you know, from a practical perspective, it seems to me as though contamination is a much, much bigger risk now than it probably ever has been. And what we find as well is that staff are under much more pressure, because obviously they're under pressure to see many more patients. And what happens is then obviously staff get under pressure to get the patients through the chairs, because we have so many in our caseload now all of the time. And that potentially means that if staff are under those additional pressures with all of those extra treatments, there may potentially be a reduced compliance with the safety measures, because you're trying to do things so quickly all of the time. It's actually quite difficult to maintain the appropriate levels of protection. Again, there's more contamination. So because we've got more treatments and we've got more patients, things like it's been shown in quite a lot of studies around patient toilets. They're very highly contaminated. In one of my chemo units, we have one toilet and we see around 60 patients a day in that unit. So if you imagine all of those patients using that same toilet, their urines are all contaminated with whatever SACT they're receiving. And so, that becomes much more difficult to manage, that contamination. And then also things like your drip stands, your pumps, your computers, your phones. It relies very heavily upon the nursing staff doing the right thing all of the time. So making sure that they are removing their PPE when they've, given actually administered the SACT, and making sure they wash their hands and have that appropriate kind of level of practice that they should have. One of the things that's happening more on the SACT units now as well is drawing up of medications. So what we're seeing is a shift from our aseptic unit. So particularly with all of these newer immunotherapies, monoclonal antibodies, they're becoming subcut. And that means that shifts the manipulation of the drug into our sort of chemotherapy units. And again, the increase in drawing up of those medications means there's a high risk of contamination with that. A lot of these newer drugs, as I say, they haven't been around for all of them. A lot of our immunotherapies, and particularly the newer bispecifics and some of the ADCs, they're really quite new. And so actually we don't really know the longer term effects of those types of therapies. We don't know what level of contamination they have. We do know that some of them are classed as hazardous in many places. But unfortunately in this country at the moment, we don't have that kind of list of those drugs that are classed as hazardous from a SACT perspective. And the other thing is around decontamination and cleaning. And again, there's been lots of studies around decontamination, and we know that, decontaminating areas where there are SACT drugs around is incredibly difficult. And we don't actually have a particular cleaning regime where we know that those hazardous drugs get eliminated by that decontamination process. And actually, trusts have generally contracted out their cleaning, and so we have, in my trust, we have an external contractor that comes in, and we may have a different cleaner every day. So it's not like you've got a cleaner who can understand what the area is and that they know what kind of cleaning methods need to be used in that area. And again, the nursing staff, because they're under so much pressure, it's hard for the nursing staff to keep on top of things because you're trying to get through that long list of patients every day. So decontamination and cleaning is another area, probably a massive area that I'm not going to touch on really, but is another thing to kind of really be thinking about in the current situation. So what do we get told? Well, we get told we've got to do risk assessment, which is all well and good. And I've just got a little example of what a risk assessment table looks like there. But what we're not really taught as nurses is how to do an occupational health risk assessment. We're nurses, and so we're told in your area you do a risk assessment, which is fine. But actually, we're not really trained to do that. So we do the best that we can, but we don't always know exactly what that risk is. And a lot of guidelines suggest that risk assessment, particularly around the use of PPE, should be according to the type of HMP. And of course, with nurses having to give so many different types of treatments, actually, it's all very well saying, well, this drug is low risk and this drug is high risk, but actually, we're giving a combination of those most of the time. So, in a way, what's the point? Because ultimately we should be giving the highest level of protection, because we can't think about when you're treating 10 different patients with maybe 20 or 30 different drugs in a day. We're not going to be sitting there thinking about, oh, is this a high risk drug or is this a low risk drug? I'm going to change my PPE to something different. It's not a practical thing to do. And as I say, most patients have these combinations of different treatments, and information is not really readily available to nurses. So, as I say, we don't, particularly in this country, well, not particularly in this country, in many countries, there is not a definitive list of, what is classed as a hazardous drug and what isn't. And so how do we know then what's a high risk and what isn't a high risk? And who is it that carries out that risk assessment? As I say, in all of our areas, it's nursing staff, whether it be me or the nurse in charge or the one of the unit managers. We all do our own risk assessments. We have some training around risk assessment, but it's not our area of expertise. And so, you kind of feel like we do these things, but actually they're never 100%. I don't feel that they are 100% accurate, and I can't guarantee that risk assessment is carried out completely appropriately all of the time. And the other thing that we know, and I know Alison will probably touch on this as well, is that PPE use is very variable. And again, that can come down to many different factors, which I'm sure Alison will talk about. From a practical perspective, it does depend on individual SACT units in terms of what PPE they actually have available. And it also depends on the nursing staff themselves and whether they will protect themselves to the level that we would hope that they would. And again, when nurses are under so much pressure, day in, day out, patient after patient after patient, it becomes much more difficult to comply with what we would class as the best, PPE protection. And I just wanted to include this slide here because this shows the difference between essentially how manipulation is carried out in an aseptic unit. So you can see on the left-hand side there, that's what we would usually use in the UK, which is what we class as an isolator cabinet. It has obviously pressure, it has specific pressures, it has specific cleaning, and there's a lot around within the manufacture of aseptics. There's a lot around obviously contamination of the drug rather than contamination of the person, but at the same time you can see how much protection that person has while they are manipulating the drug, and rightly so, they should have that, because ultimately they're dealing with raw product and they're dealing with that all day every day. So, but we know that there are very specific measures in place for that. So we have very specific measures around aseptics and manufacture and manipulation of hazardous drugs, and things around that, exactly what PPE they should wear, exactly how that process should be carried out, and also the fact that they shouldn't be doing this for longer than a set period of time, so that they swap out with other members of staff, so that one person isn't doing that process, for the entirety of a shift. The right-hand side is actually a picture of one of my nurses on one of my SACT units, and you can see a lovely see-through apron there, and you can see one pair of gloves with the whole of the arm showing. So you can see that we don't even have arm protection, and we do have a little bit of a fight with infection control when it comes to this in-house, because infection control insist on bare below the elbow. So, so anyone visiting a unit or anyone coming onto a clinical area in a hospital will always be told you must be bare below the elbow. So that's why you see when the politicians come on and they all roll the sleeves up and they have to be bare below the elbow. Well, obviously that stands for us too. So, if we're bare below the elbow, we've got quite a large area of potential contamination there, haven't we, for when we're giving all of these multiple range of drugs all of the time. So I just wanted to throw that in there just so you can see that comparison of what we currently are doing on, I would probably say, the majority of our SACT units, and how different that is. And I mentioned briefly before, but the other issue that I feel is becoming a real issue is the move to subcutaneous administration. So a huge amount of our therapies now, and particularly all the monoclonal antibodies, so a lot of those newer drugs, immunotherapies, monoclonal antibodies, there's been a massive shift towards changing the route of administration to subcut. And while, yes, this provides time, it releases time in the chair, so where it might have been a 2-hour infusion, we're down to a half-an-hour appointment for an injection rather than an IV infusion. It means obviously we can get the patients through quicker a lot of the time, but what it does mean is that there is that increased risk of exposure for the nursing staff, because what it's doing is it's shifting that kind of drawing up process and manipulation process from the pharmacy aseptic units into the clinic. And that means nurses are therefore drawing up from a vial monoclonal antibodies and other types of drugs into a syringe. Some of those are not being done with a closed system, and I know that for a fact. We've got many, many trusts that still don't use closed systems. So for them, it will literally be a syringe with a needle, drawing up one of these drugs, and then administering it to the patient. The other issue around that is actually when you're giving a subcut injection, you cannot guarantee that all of that drug is going into the tissue. So what you do find is that drug sometimes will leak out. A lot of these MABs that we give are very big injections. They're 5+ mils. Now, 20 years ago, you wouldn't have dreamt of giving a subcut injection that was any more than about 1 mil. We give some of them are 10 mils, 11 mils, I think, probably for some of them as well. These are big, big injections that we're giving via a subcutaneous route. And actually, you cannot then guarantee that all of that medication is going to go into the tissue, because it does leak out. And I've had it happen to myself when I've done it, and I've seen it happen to other nurses. So there is a much higher risk of exposure when you're giving through that route, potentially, than when you're giving it IV. I've mentioned about the drawing up. So we know a lot more nurses are drawing up these types of medications. They're often doing that within a treatment area. Quite often there's not adequate ventilation. We don't even have a window in two of my treatment areas. So therefore there is, we haven't got those engineering controls that are recommended for areas where drugs are manipulated. And they are very often inappropriate environments. I dread to think with this weather at the moment because the temperature's obviously going up. And obviously there's a higher risk as soon as that happens within those treatment areas as well. Um, and we don't have any guidance around this. There is no guidance around how we should be giving subcut medications. There's no guidance around whether these drugs are hazardous or not. We still don't have that for the majority of these medications. And most places, I really don't see that they have adequate protection measures. I know there are some centres that have implemented things. I know there are places that have implemented isolators, desktop isolators, so that the nurses can draw things up in an isolator, which I think is absolutely brilliant. And to me, that's the most appropriate thing to do. But I also know there are many trusts where they don't even use a closed system to draw things up. And again, they've got a wafer thin apron and a pair of gloves, and that's it to protect themselves. My personal view on this, and I think there's probably quite a lot of people, is this is perfect for enabling self-administration. And I think that that's probably the way that we need to move to get things out of the chemo units. We keep on talking about capacity. So a lot of the work we do at the moment is around trying to get things out of chemo units as best as we can, because we're trying to reduce that, that massive number of patients coming in every day. To me, one of those ways is through self-administration. And there's something really interesting about that, because there's one drug, which I won't name, or the company, that has an actual device that the patient can use, and it's kind of a disc device, and they have to just load up the vial, they have to load up the medication into the device, but that device then is just put onto the patient's abdomen, and it just slowly injects over the period of time that's recommended. So there are things out there which I know, it's a possibility, and I think they're the things that we really should be looking at more to protect the nursing staff. One of the other things I should have said about the subcut medications, not only are they big, they have to be given over set periods of time. So sometimes that's 5 to 7 minutes. So you're as a nurse, you're sat there for that period of time with a syringe, having to give it slowly over 5 to 7 minutes, and that has loads of other issues in itself. We see nurses with bad backs at the moment because they're having to sit in the same position. So there's lots of reasons why it would be preferable to encourage patients to administer these medications themselves. And all of our guidance at the moment from an NHS perspective is around care closer to home. So if you look at the 10-year health plan and the cancer plan, the focus is very much around care closer to home. So, this is quite difficult, I think, from a SACT perspective, because it's hard to try and think of ways of doing this, because we have finite staff, we have finite trained staff who can administer these medications. What concerns me about this is that potentially we may be diluting the workforce, because if we're pushing things out to patients' homes, actually, how do we manage the more complex that we need to keep into our SACT units? But there's a lot of focus around this at the moment. And a lot of actually some of the HMP guidelines that I've looked at, they mention about centralisation of practices to reduce risk. So if we're saying we need to centralise these types of practices, then, when we're pushing things out to home, how do we manage that in a reasonable and sensible way that protects everyone while we're doing it? So something I think is coming everyone's way. We've all got to think about how we do this. We've got to think about how we get care closer to home, but equally we can't jeopardise the safety of our workers while we're doing that. I have given SACT at home. It was a job that I did many moons ago. I have to say it was a lovely job. But the amount of kit you then have to take with you to ensure that you are carrying out things as safely as you can is quite phenomenal. So actually, how do we make sure that we are protecting nurses when they are, if they are out and about giving SACT in quite a different way? And again, that's something I think we all need to really kind of focus on. So I'm going to summarize there. So basically, we know everything's becoming more complex, all the treatment's becoming more complex. We're seeing more patients than ever before. We see in our units, and we're relatively a small service across 3 sites. We've got 3 hospitals. We see about 140 patients a day. who are all having very, very different treatments, different SACT treatments. You know, some centres are way beyond that. It may be up to 200 patients a day, and that's just a huge amount of exposure risk to me, because all of those patients will be having different types of SACT. So the occupational exposure risk is greater than ever, because that number is huge, and not only the number is huge, but all those different types of treatments are huge. You know, a massive range of treatments. Risk assessments should be done, but often they are lacking in specific details, and they're not really they don't necessarily direct people exactly what they need to do, exactly what PPE they should be wearing, and that needs to be looked at. And we do have this massive shift in methods of administration and these newer novel therapies, and we're just unaware of what that risk is ultimately. And as I say, you know, we've got to think about care closer to home and how we can manage that in the safest way possible. And I think that's me done. Sorry if I've gone over.
Thank you so much, Sam. If anyone has any questions for Sam, please put them in the chat. It was a fascinating presentation, especially looking at the new forms of SACT and what that means for healthcare workers, especially in different environments. There's a comment from Lisa in the chat talking about working for a home care provider, giving chemo in patients' homes. Which might be a better workflow for the person delivering the chemo, not in a clinical setting, but lots of the bags of equipment is life-changing for the patients. Okay, if anyone has questions, please put them in the chat. I'll just do one from Kate for you, Sam, there. How do we get systems to change? Great question, and partly the reason why I hope everyone's here today. I see the changes made from the pharmacy side due to capacity, but it feels horrendous these decisions have contributed to greater nursing risks.
Yeah, absolutely. And I think that is the really difficult thing, is that because everyone's under pressure, you know, everyone's under pressure, and the capacity is so tight everywhere. And I can understand why, you know, where pharmacy would push back, but at the same time, you know, the nurses need to push back, because actually, you know, we're all under pressure, we're all under the same pressure. And why wouldn't we then, you know, sort of shout up about it a bit? Because actually, you know, if the expectation is that it's coming to the nurses, then we need the protection measures in place. Because you wouldn't go to a pharmacy area and see, you know, a technician drawing out of a vial outside of a cabinet. It just wouldn't happen. So why is it okay that that happens in nursing, but it won't happen within a pharmacy aseptic area? So I think, you know, there's got to be change. Hopefully that will start happening. We have seen a lot of momentum, obviously, and with the support of SHBN in particular, you know, it has been to Parliament. We are looking at another parliamentary roundtable soon. So I'm hopeful that things will change now. I think from a very basic perspective, in your own trust, there are things you can do, and the first thing really would be to go to your health and safety department and make sure they're aware of what's going on, because a lot of the time they don't even know, you know, the potential risks that people are taking. They don't understand, and I think it's probably a good place to start to think about how you can change things locally within your trust.
Thank you, Sam. And it's really important that everyone is on the same page. And we speak a lot to many different healthcare professions, maybe not even nurses and pharmacists, where there's still exposure happening. There's ancillary staff, there's cleaning teams, there's lots of other people in the hospital. There's some fantastic organisations all working to try to improve safety standards currently, that we are liaising with from pharmacy and nursing. And it's important that everyone is pulling in the same direction. There's a few more questions here, but we'll move on due to time. Just a quick point, someone's mentioned about risk assessments and detail about risk assessments. Please do send me an email afterwards. I'll put my email in the chat. There's lots of resources available around risk assessment, especially through our colleagues at the Royal College of Nursing, and we'd be happy to put you in touch. So now to hand over to Alison for another presentation. Thank you, Alison.
Thank you. Can you see my screen all right? Yeah, fabulous. Yep. Okay, so yeah, thank you for inviting me. Very excited to be involved in this. So I'm really grateful for being invited. And thank you, Sam, for paving the way for me beautifully by looking at the landscape going forward. I'm going to kind of do a bit of both, looking backwards and forwards. And I probably have been watching too many true crime documentaries, because I've taken this on looking at the case of the lesser spotted HMP ostrich 8 years on. So this is a case that's been going on for many, many years that we've been involved in. And I wanted to take this opportunity to sort of have a look at it and review the case and see, what evidence we have and what other leads we need to sort of follow, really. So I'm not going to go through this in any detail. We already know this. If you've heard myself and Sam speak before, we've literally done this to death, but we know these drugs are hazardous. We know that they are mutagenic, carcinogenic, teratogenic, reprotoxic. They're just not great. Let's just say that. So I'm not going to go into that in too much detail. And we also know that we have these guidances, Health and Safety at Work Act, COSH, etc. And on top of that, we've got a layer of recommendations and guidance. And within institutions, you should have policies as well. So we know that there are things in place to protect workers. So if we're looking at HMP bingo, we're not doing too badly. However, we haven't quite got a line yet, and we definitely haven't got a full house. So we need to carry on playing bingo. So unfortunately, the case cannot be closed, and we need to continue working on our lines of inquiry. So what I did was, myself and Sam published a study in 2017, so 8 years ago. We've been working on stuff well before that, but we actually published some data in 2017. And more recently, Campbell and Dixit in 2025 did a very similar, they're not exactly the same, but a bigger study looking at nurses administering HMPs. So I thought it would be a really good opportunity to compare and contrast what's changed in those 8 years, and has anything changed, and what still needs to be changed. The good news is things did change. So what we know is that education and training is now much more widespread, which is brilliant news. And policies and guidance are more embedded. I'll come back to that in a moment. So the closed system transfer devices, CSTDs, are being used, slightly improved in the last 8 years, but still very inconsistent. As Sam mentioned in her presentation, not all places use these devices to administer the drugs. And PPE use is routine now, but it's not optimal. And again, that goes back beautifully. Let's see if we knew what we were talking about. Sam's presentation, where she showed you the picture of what nurses wear in comparison to what pharmacy wears. So although it's routine, it's not optimal. So what Campbell and Dixit, I've got to be careful what I say, 2025 study showed was that PPE, as in aprons and gloves, were worn, but it wasn't optimal in terms of the gloves weren't particularly designed for chemo, so the permeability times were a lot shorter. And you saw the aprons that nurses wear, which is not optimal. It doesn't cover the bare below the elbows. It doesn't cover, for somebody like myself, it only covers one side of my body. It doesn't cover the whole of the uniform. So long sleeve gowns, etc., weren't being used. But the evidence of harm is much, much clearer now, because what we showed in 2017 was absolutely replicated in 2025 in terms of the adverse effect nurses were identifying in handling these agents. So let's look at what hasn't changed and the leads that we still need to follow. So education and training is still inconsistent. It's more widespread, but it really depends on where you work and where you study and budget. So there's no consistency in training and education at the moment, but that hopefully is going to change. There's work going on. Guidance is still not fully implemented. So whilst it's embedded, so the guidance and policies are there, they're not actually being implemented. And we've shown that has caused practice to be inconsistent. The big one, and Campbell's study also showed this, is attitudes and behaviour towards safety is still inconsistent. Campbell talks about, and she talked about it in a previous webinar, is we've got this split community. So some nurses will say, look, I've been giving chemo for absolute years and I've never had a problem in making a mountain out of a molehill. And another part of the community is going, there is real risk here and we need to be protected and I've experienced adverse effects. And I personally think this is one of the biggest issues we have that's blocking us from moving forward. And what has not changed? Exposure risk is still present, and we always will be. So, we can mitigate the risk, but the risk will always be there. So for me, the problem has shifted from a lack of knowledge, which is amazing, because when we did our study, there was a massive lack of knowledge. I'm hoping me and Sam have something to do with that. I'll just take a bit of credit for that. Not all of us, obviously. And it's moved towards now a failure of implementation and behaviour change. So to change behaviour, we need to be aware of what we're doing and what we should be doing to be able to make the changes in behaviour. So let's have a look at the target behaviours. What do we want? And I'm talking from a nurse perspective here, because obviously I'm a nurse and the two studies were about nurses, is what's the target behaviour? What do we want nursing staff to do? Well, we want consistent, optimal PPE use. So that's, as I said before, optimal PPE, not just gloves and aprons. We need universal CSTD use. And that goes back to that, some places will use it, some won't. Really depends on budget. It's as simple as that. And it shouldn't be. Everybody should have this protection. And we need safe handling across the full pathway. So that's right from reconstitution through to patient waste. We need to normalise safety. At the moment, safety is sort of negotiable. Yeah, we might provide you with CSTDs. Yeah, we might provide you with a long sleeve gown. We need to normalise it, and it should be normal that we are safe and not negotiable. So looking at behaviour change, I'm going to use the behaviour change wheel to kind of demonstrate this. And the COMBI behaviour model says that all behaviour is based on capability, opportunity and motivation. So this green inner hub. So in this case, the capability is high knowledge and training, which we have. This knowledge now has changed and improved, but training isn't standardised. And again, that's something we need to look into. The opportunity, there are barriers that persist within the system that persist, and we've got inconsistent adherence to guidelines. And the motivation, it's all about culture and habits that influence practice. And as we've got that split community, that is really quite difficult to manage. As I said, safety needs to be normalised. This is my new phrase. I'll be saying it a lot. Sam says mushrooms. I'm going to say safety needs to be normalised. So if we work outwards in this behaviour wheel, so we're on the red layer now. So this is interventions that can obviously impact behaviour. Now, there's loads that we could pick out on here, and the yellow ones I've looked, we could do that straight away. These are really important in this particular scenario. But as an academic and educationist, of course, I'm going to focus on education because I've got time to do more. So education is widespread, but it's insufficient alone. And as an educationist and an academic, you probably were surprised that I would say that, but it's true. Knowledge cannot change the world. It's powerful and we need the knowledge, but on its own, it's not enough. So we need more. It's not fully standardised or regulated across the UK yet, which means behaviour remains inconsistent. So what we need is this shift. We need to shift to mandatory standardised national education, and I know that a lot of the cancer education hubs are working on that at the moment, and they need to be regulated by governance. And we need competency-based assessment to be ongoing and monitoring. So it's not just a one-stop shop, yet we signed you off as competent. It should be that they're observed in practice, audits are carried out, and monitoring to make sure safety is being adhered to. So the key message in terms of education is that safe practice must be enforced by systems and not reliant just on individuals, because it's quite easy to push it back to individuals, but actually it's the system and the organisation needs to take responsibility as well. So moving on to that outer layer then, and this is all about policies. So policies that can then help with the interventions, which will then help with the behaviour. And as you can see, guidelines, regulations, and legislation are key points here. And this is what we're talking about. This is what Sam was talking about towards the end of her presentation about making those guidelines, legislation and regulation of how to handle HMPs, which is what we're pushing for in Parliament with this campaign. Guidance does exist. We know it exists. It's existed for years and years and years, but it's not consistently enforced. So it, again, depends on where you work, what country you work in, for starters, let alone what trust or which unit you work in. So there's no consistency, certainly across the UK or across the world. And at the end of the day, and I've said this before, these drugs are these drugs. Regardless of where in the world you're giving them, they work the same and the risk is the same. So actually, you know, we need to standardise that across the world. But that's for another day. We'll start on the UK to start with. So the shift is we need to normalise safety. Safety is not negotiable and shouldn't be negotiable just because we're nurses and we don't often, you know, push back. We need to mandate the use of CSTDs, and that's what the campaign's pushing for too. I mean, to me, it should be law, but again, that's for another day. We need to standardise optimal PPE requirements. So everybody should be using the same and it should be appropriate for handling HMPs, and should meet that requirement. And organisational accountability for providing optimal PPE and CSTD. So if they're not providing it for their workers, they should be held accountable, as it would be in any other business or organisation. Why are we different? And there should be links to compliance to organisational accountability. So if you're not compliant with the health and safety guidance, there should be accountability. So the key message there is we need mandatory standards, stronger governance and accountability embedded into systems and organisations. So in summary then, we know now that knowledge failure is no longer the key issue, which is great. Tick that box. Fabulous. But it's not enough on its own. Implementation failure is the key issue here. And safety culture is a key problem that we need to overcome. We need to change the mindsets of nurses that they are worth being protected. And that safety requires system level enforcement. So we can't rely on the individuals on their own. That is not sufficient. It's a big ask. It's not appropriate. It has to be from a system level point of view. So we need a change. We need to change. So my recommendations going forward with this case is that we need to treat occupational exposure as a preventable harm, because it can be prevented if we mitigate the risk. We need to standardise training. We need to mandate or legislate, ideally, the use of safety measures and engineering controls when handling HMPs. Embed safety into systems, not just individuals, and hold organisations accountable so that we can protect the people delivering the care, every treatment, every day, every time. That's me done. Thank you.
Thank you, Alice. I've seen you both present before, and every time it's always excellent, and it honestly gets me motivated and fired up to continue doing the work that we're doing. So thank you both. There's a few questions in the chat that I'll just talk through, and I'll maybe direct them at the two of you, and we can talk them through. The first one is a comment that I very much agree with from Marion. She says, as a health and safety professional, she supports a guidance and risk assessment process. However, guidance around HMPs is absent. It's therefore hard to interpret the measures we need to advise and support on. And then she calls on the HSE to have a directive and wider consideration for unifying safe practices across healthcare. This is one of the unifying objectives of our campaign. The thing is, guidance does exist. There is a lot of guidance out there. It just hasn't quite reached the UK in a formal way. So if it's on an individual level, please do search for guidance because it exists. Unfortunately, it's just not very accessible, and we do need formalised standardised guidance through the HSE in the UK. But Alison, where do you see that coming from? Maybe why haven't we got such a clear picture?
Okay, so where do I see that coming from? Well, obviously, why reinvent the wheel when we know there's guidance out there? We need to be pulling together and bringing that all together. Sam's going to say it, I know, but I'll jump in ahead of her. We actually were part of the working party that helped write the European recommendations. And I know that they're not perfect, but they're certainly better than anything that was in place before. But unfortunately, and I'm going to say it, Brexit, we can't use them because obviously we're not in the UK. And I think, if I'm really honest, I think the UK needs to stand up and go, do you know what? We're not that special. And these drugs are the same wherever you are in the world, as I said before. And we need to work together and all right those first of all, the hazardous list needs to be completely updated. As Sam mentioned, the drugs that they're using now, those need to be looked at as a matter of urgency. It scares us really, really worrying. And all work together as a globally, maybe start, with Europe first, but we need to be talking to each other, and Brexit should not stop us protecting our staff, in my humble opinion. But there you go. Sam, I don't know if you wanted to add.
Yeah, so I've just done a little bit of work looking at a load of different guidelines, funnily enough, because I'm part of UCONS as well. So UCONS are doing quite a lot of work at the moment looking at this from many different perspectives. There's about 6 different working groups. So I have just looked at international guidelines and I picked out 5 of them. So there was USP 800 for America, there was an Australian guideline, there was the HSE, obviously from the UK, and the European guidelines, and the ISOP ones are the ones that I looked at. And actually, they are massively varied in terms of what they do recommend, and I think that's probably what makes it quite hard because, ideally, you almost want to put them all together and kind of maybe we could use some AI or something now, just kind of jumble them up and spit out the right one, because some of them are very directive around PPE use. I have to say, particularly, the European and the USP 800 are quite directive around that. USP 800 in particular, I think, is the optimum because it recommends full PPE and the CSTD and everything else. And within the states, it is legislation, so it's not just a guideline. It's far more than that. So, and ideally, that's kind of the place that we want to get to. But again, that they are all out there, and I have to say, when I looked at them, I was kind of like, yes, it's all in here. It's all in here. We shouldn't be looking, to create something new. It is all out there. Absolutely, Alison's right. The important thing is getting the list. We need to know what's a hazardous drug, and we don't even have that. And I know it's hard with some of the newer therapies, but ultimately, there's got to be a way of that risk assessment being done properly so that we can get, a better guide for what is, and like I say, it's not just about that. It's about when you've got to think practically of what goes on in a unit. One nurse will see 8, 10, 12 patients in a day, and they'll all be having different things. There's no good saying, oh, you're giving that MAB, you only need to wear gloves and apron for that. Oh, but the next drugs are cytotoxic. But actually, we're in that environment. All the drugs are being given at the same time in that environment. So actually, shouldn't we just be protecting them to the maximum level all of the time? Because there's stuff in the atmosphere, well, not the atmosphere necessarily, but stuff in the environment around us of every type of drug. So to me, it makes I find that all a little bit of a waste of time, if I'm completely honest with you. That whole risk assessment around individual drugs doesn't matter when it comes to a unit because we're giving multiple. So there's multiple everywhere. So you should be protecting the nurses to the maximum level the whole time.
And like you said, Sam, about the USP being sort of the top hierarchy, then actually we should be applying that. It's as simple as it should all be under that highest. Everybody should be under that. There should be no derogations between these. You go for the top and protect everyone because we're worth it. But that's the fight we've got.
Thank you. Another question here from Ian Johnson about labelling, and I know that this is a huge issue. You mentioned there about the list of hazardous drugs, which currently we have an EU list, which was published a couple of years ago and is already outdated and needs to be updated. We don't have a list in the UK. And while the drugs are often the same compounds internationally, they can have different names. And labeling of the drugs is incredibly important for the person delivering them to be able to identify whether it's hazardous or not. There are lots of classifications in Europe. It's category 1A, category 1B, carcinogenic, mutagenic, or reprotoxic. But often that information is only available on the safety data sheet from the manufacturer, and it's not accessible easily in practice. So Ian's saying, what does the labelling describe in relation to the hazardous properties? Do you have any advice on control measures? And if none, would be great to start managing risks. So about awareness and visibility of the hazard, how is it presented in practice, and how might we improve that, Alison?
I am actually going to throw that to Sam because she's in practice at the moment, so she'll be more up to date with the labels, if that's okay.
Yep. So essentially, we have an outer bag that's placed from pharmacy. So all of our IVs will have a sort of either an orange or a black bag, and that's just basically telling us that it's a hazardous drug, essentially. But we will have that on all of everything that comes from aseptics, basically has one of those bags over it. So there's no differentiation between then if it's a cytotoxic or if it's a MAB or whatever. Basically anything that's been made in the isolator, anything that comes up from pharmacy that's been screened and they then put a bag over the top of it, will just have that kind of coloured bag. And yes, there are labels that will say with the cytotoxics, they're cytotoxic. But again, it sounds terrible. We don't pay that much attention to detail when we're on a chemo unit. You know, you're giving 20, 30 drugs in a day. You are not going to be looking at every label that comes up on a drug. You know, you need to be implementing these measures all of the time because, you know, as I say, I'm not going to look at one bag and think, oh, I'm all right giving that. I'm just going to wear my gloves for this one. And then I'm not going to look at another one and think, oh, I need my mask and everything else for this one. So again, I get that that's important, but at the same time, you know, there are so many hazards in one place at one time that actually it almost becomes irrelevant because it's all hazardous effectively.
Yeah, and that goes back to the behaviour again, doesn't it? Because people don't see those hazard warning labels anymore because that's white noise to them because that's what they deal with all the time. So it's changing that behaviour, making that safety normalised and going, if you've got a label on, you need to take caution. I don't know how else we can do it because like bright yellow labels with caution and
we have them.
And we don't see the data sets. And actually, you know, on the units and RCN thought we did, and we had to say no, we don't.
We never see them.
We've never seen them. So yeah. So I suppose that doesn't answer your questions in how you can move forward though, because it just doesn't happen where in the units it doesn't get to us at that point. They've just got a label on it saying these are hazardous.
I think again it comes down to standardization, and if there was one rule that could cover all the drugs and make it visible in a way that was practical, then it would solve it. Often I think it's because it's so individualized that it gets lost, and there's a big difference between often what's in guidance and what you can actually deliver in practice, especially when you consider lots of people are overworked and tired and quite easy to make a mistake. Another question here from Rob Marlowe. Who do we need to engage with to ensure that automation, particularly within pharmacy aseptics, more universally, could shift the conversation about capacity and struggling pharmacy teams? It's a question we see quite often around capacity. I've just mentioned it from the nursing side. It's exactly the same situation in pharmacy in order to provide safer end products for nursing to administer.
That's quite, it's a bit difficult because that's more of a pharmacy question than nursing. Alison and I are both nurses, but I think the issue that we are facing now, and everyone who works in the NHS will understand this, the financial pressures are immense. And we have been told many things in the last few weeks, but particularly that financial situations are absolutely dire. And so if you're going to go with something that is a potential investment with no return on what you're asking for, you are potentially going to be turned down. And that's where I think this is why it's important that this comes from another level, because actually, you know, when you're in a trust and you're trying to get something through, I mean, I've done business cases, I've done all of that stuff. I've been lucky enough in a period of time where we did have some finance and I got a great business case through, but you know, a lot of people don't have that experience because of the fact that the NHS is so strapped for cash. So my concern around that would be, yes, I completely agree. I think that would be an excellent way, wouldn't it, to get that automation in place, definitely, to release your technicians and release your isolators and all that stuff. Absolutely. And maybe then we could make sure everything's in the lab that needs to be in the lab. But as I say, I'd hate to be the doom and gloom person about it all, but the finances are very restrictive. But in terms of who you would go to about that, I know there are companies out there that provide all of those things, and some of them certainly integrate with. I know some of them even integrate with the pumps that you have on units and stuff. We've seen this, haven't we, Alison, in other European countries? They do this in a lot of other countries, and I'm not sure why it's not really got very far in the UK. It doesn't seem to have.
Guessing it's cost, isn't it?
Yeah. I can only assume that it is.
Yeah.
Thank you. A point here from Claire, and I don't know the answer to this, but when it comes to PPE, if the risk assessment dictates gowns need to be worn for administration of hazardous substances, then this would take precedent over infection prevention control measures. And is that the same as the PPE needed to be worn for chemo spills?
Yes, theoretically, yes. It should.
Mm-hmm.
But I know what infection control teams can be like. And so, it may just be a conversation with them to make sure that they're aware of the fact that, we have a dispensation working in the SACT unit because it's more important for us to protect the staff than it is to, from an infection control perspective. So yes, you're right, it should take precedence. But, again, it's having those conversations with your infection control team ultimately, I suppose, isn't it?
Yeah, and it doesn't actually say in any of the guidance, it just says PP. It doesn't stipulate a gown for administration.
But apart from the USP, the USP does.
The USP does, and a double glove as well, which is another conversation for another day that's quite interesting. Yeah. But some units have adopted the gowns, and actually, is that best practice? Because I certainly would say it was. When you look at that picture that Sam showed you, would you want to wear that if you were giving these drugs? And I put it out to the pharmacists out there. I can categorically say most of you would absolutely go, absolutely not. So, if we can wear gowns are available and other units do it, why can't we do it? USP stipulate it. That's the gold standard. Why are we not doing that? Again, it might be cost, but do you know what? You can't put cost on somebody's safety, in my humble opinion.
Yeah, and it's an interesting point. And in my conversations with the Royal College of Nursing around how health and safety risk assessments are undertaken, there's the ALARP principle, which is as low as reasonably practicable, which leaves a kind of grey space where things like cost or capacity and resource are used as factors above safety, which doesn't make sense to me, and I think is something that needs to be looked at. So
absolutely, that language needs to change. It's a great big black hole that they get away with a lot because it's not practical, because it's not affordable. And that's what I talked to about having organisations having accountability, that they need to be accountable for putting their staff at risk. And actually, if we started fining them a hell of a lot of money, maybe they would consider putting these safety things in place. But
from what I understand, that's the case in the US. As Sam mentioned, it's legislated. There's actually financial
penalty.
For if you aren't meeting the standards. And at the end of the day, if cost is being used as a reason to not implement safer systems, cost is probably also going to be what moves the dial the other direction as well. At the end of the day, it will always come back to cost. We've got one other point here from Helen, who's talking about pharmacy aseptic units, talking about the cost of isolators and needing more space. Just a point, we are working closely with ISOP and BOPA and PAS, which is the Pharmaceutical Aseptic Services Group. And we hope to be delivering another webinar later this year from pharmacy talking about aseptics. So maybe we'll save some of those questions for them. But please also do feel free to send me an email, and I'd happily put you in touch with those organisations I mentioned. We have 2 more minutes. I was just wondering if Sam or Alison had any concluding points. I know there's quite a few messages in the chat that I've missed, but is there anything you'd like to say before we finish up?
I think just it's raising awareness of the situation we are in today, because it's very, very different than it was, 10 or 15 years ago. And it's really people just thinking much more carefully about what we're doing and how we're doing it. And I think, you get a lot of push from a, political, governmental, whatever, perspective to do things in a certain way, but actually does that fit with what we should be doing from a safety perspective? And I think people just need to be thinking more about that, because it's all very well saying we need to shift this out, we need to shift that out, we need to go, but actually, is that going to jeopardize the way we our safety? Is that going to jeopardize safety by doing those things? And I think they're things we really need to be careful of.
Thanks, Sam.
Yeah, and for me, it's just, I think we all need to work together, multi-professionally, and across different countries to all get this, to the best that we possibly can. We need to normalise safety. At the end of the day, it's not negotiable.
Thank you, Sam and Alison, and thank you everyone for giving up your time today for this webinar. There will be more later in the year. This has been recorded and will be uploaded. Please keep in touch with the campaign, and thank you so much. Have a lovely afternoon. I hope you stay cool.
Thank you.
Thank you.